We are live.
Welcome everyone to this yet another web symposium on combating antibiotic resistance with high concentration levofloxacin, which is at the platform of All India Ophthalmological Society. I would like to welcome all the viewers who are on the web or who are on the Facebook or on our YouTube channel. Antibiotic resistance is a topic which is very relevant in the current times because of the bugs which become resistant over a period of time. And levofloxacin is the newer drug which has come to combat the same. I have with me my co-moderator, Dr. Prashant Kark, who needs no introduction actually, but he's the director for the LB Prasad Eye Institute in Hyderabad, India, where he serves as a senior faculty in the Cornea and Anterior Segment Services, which is now known as the Tej Kohli Cornea Institute. He's the Paul Dobot Chair of Cornea, Kalam and G. Reddy Chair of Ophthalmology, Director of Eye Banking Services, and the director of Vijayawada campus of the organization. He has several path-breaking publications in the field of ocular infections, more than 170 publications and several book chapters, which have actually changed the way we look at ocular infections. He is the recipient of several major grants, which include the Wellcome Trust UK, the Newton Baba Fund, which is a joint grant of DBT, Government of India, and Medical Research Council UK. He is currently the board member of the Asia Cornea Society Infectious Keratitis Study Group A6, the Eye and Contact Lens Association, the International Joint Commission for Allied Health Personnel in Ophthalmology, and the Global Advisory Board of the American Academy of Ophthalmology. He is the recipient of several awards, to name a few: Senior Achievement Award by American Academy of Ophthalmology, Achievement Award of APO, membership of UKRI, International Development Peer Review College, and he was also the runner-up for the very coveted Newton Award. And he has served as a board member and president of the Ocular Microbiology and the Immunology Group. So welcome, Dr. Prashant Kar. And we would now begin the presentations, and it is my privilege to introduce the first speaker to you, Dr. Savitri Sharma, who is going to be talking about update on the epidemiology and antibiotic resistance of ocular infections. Again, she has changed the way the microbiology, the ocular microbiology looks, not only in India but also globally. And she joined LV Prasad Eye Institute in 1991 and has done several research projects. In fact, discovered several of the ocular microorganisms. And I think she's going to be talking something about that as well. She's again been the recipient of several grants from DBT, CSIR, DST, British Contact Lens Association, and she was involved in the development of the vision chip under CSIR grant. She has been the editor-in-chief of the Indian Journal of Medical Microbiology for 2 terms and the president of Indian Association of Medical Microbiologists in 2008-9, and the president of the Society for Indian Human and Animal Mycologists in 2012-2014. She has more than 25 awards to her credit and has authored a book on ocular microbiology for everyone to read, and has guided several of the PhD students. And her keen interests are in the virulence factors of Fusarium species, molecular diagnosis of eye infections, ocular microsporidiosis, hospital infection control, etc. So with this, we move on to the first talk by ma'am. Ma'am, please, can you share your screen?
Yeah, thank you so much, Dr. Sharma. It's an honor to participate in this very important webinar with respect to a promising drug in ophthalmology. I thank AIOS and Santain for organizing and inviting me to speak in this forum. Good evening to all of you. My presentation would be confined to discussion on methods of testing antibiotic susceptibility, its interpretation, and epidemiology of antibiotic resistance in ocular infections. I'll now share my screen. Let me know if it is visible.
Yeah,
I'll make it full screen. Yeah, so there we go. We know ocular infections are caused by a variety of organisms, and I would not like to deviate. There'll be so much to talk about them. Let me just be with the relationship of bacterial infections to antibiotics in this talk. And we know that antibiotic, the birth took place way back in England when Alexander Fleming saw that a bacterial colony of Staphylococcus was inhibited by a growth of fungus, which was penicillium. And he knew there's something this penicillium is producing, which is inhibiting the bacteria. So thereafter, large number of antibiotics were discovered. They were mostly produced by either fungi or actinomycetes. And of course, some are synthetic, like fluoroquinolones. Even when there was just the birth of the antibiotic and it was mass produced in 1940s, used extensively in World War II, within a year, Fleming himself knew that there is resistance developing to penicillin. And it didn't take long for penicillin resistance to develop, and the need for other antibiotics started showing up. Over the years, so many new antibiotics were discovered one after the other, and resistance went on developing one after the other. So we are at this juncture when we really have to worry whether we are going to have good antibiotics in future to fight the infections. Now, decreased susceptibility to antibiotics, which is called drug resistance, is actually the fight for survival of the bacteria. It needs to survive, and we try to kill it. So even before there is actually onslaught of the antibiotic in a population of bacteria, you have various stages of bacteria which can mutate, or they do mutate at the, let's say they develop into 10 to the power 7 organisms, one mutation definitely would take place. So in a population you have susceptible, and some of them might be resistant, but when you give antibiotics, the resistant ones get selected. So it's a selection under pressure. And then what happens is the susceptible ones wean away or die away, and only the resistant ones grow. Usually, this refers to many pathogenic organisms and not just bacteria, and it also refers to actually cancer cells which develop resistance over time. The bacterial resistance can be intrinsic. Like, for example, paulines, which are antifungal antibiotics, will not work for bacteria just because the bacterial cell wall does not have sterol. It requires sterol for adhesion, and then it has to work. But in bacteria, mostly we see acquired resistance. The genes of the bacteria carry the resistant genes, and mutation actually brings about that change, as well as the bacteria can transmit. If one becomes resistant, it has a resistance gene, it can transmit by various methods. Like conjugation, the bacterial cells can join together with the help of a tube, and a fertile bacteria can transmit its genes, which are born on, let's say, something called plasmids, which are extra chromosomal genes. They can transmit into the other one, and all the daughter cells will be having the resistance genes. Similarly, there are viruses which attack bacteria, and these viruses are called bacteriophages. When they enter the bacteria, they can integrate with the DNA of the bacteria. And when they come out after multiplying within the cell, they carry the gene along with them. And then they go and infect another bacterial cell, and thus the bacterial genes are transmitted to other bacteria. The third one is just naked DNA in the environment, in the milieu where the bacteria is growing. And if it carries some gene of resistance, it can just be sucked by the bacterial cell, and then it will integrate in the chromosome, and then it will start into the all daughter cells. So you see, there are so many varieties by which bacteria knows how to survive when you try to kill me with antibiotics. Let's come to ophthalmology. It is a very, very big problem in systemic diseases. In ophthalmology, here is a study which we did at Bhubaneswar LV Prasad Eye Institute to look at microbial keratitis and in vitro susceptibility of the bacterial isolates over a period of 8 years. We divided the years into two sets, 7 to 10, and then 2011 to 14. You can see the gram-negative bacterial infections have actually been reducing over the years, and gram-positive have been increasing. Coming to the antimicrobial susceptibility of Streptococcus pneumoniae, which is a very, very common organism, one of the foremost ones causing microbial keratitis. The susceptibility to this organism has remained susceptible to many antibiotics, and these are all the fluoroquinolones. You can see over 90% of. So resistance is not a problem in Streptococcus pneumoniae, and we can treat with many antibiotics, but it is a big problem in Staphylococcus organisms, both aureus and coagulase negative staphylococci. Resistance is quite a bit in staphylococci to fluoroquinolones, and we are left with very few antibiotics like cefazolin, cephalosporin groups, and vancomycin to treat staphylococcal infections. Pseudomonas is actually a very dreaded organism, and we think in terms of multi-drug resistant. But overall, it's the number of Pseudomonas which are resistant to antibiotics are not very high. When they become multi-drug resistant. But you can see here they are quite susceptible, very high numbers, to most of the fluoroquinolones, though they are not so well tackled by the aminoglycosides. Another a very recent study from the US, very beautifully done. I'm very impressed with this study. The whole country has been mapped in terms of ocular infection isolates, and MIC, minimum inhibitory concentration, I'll be talking more about that later, have been used for finding out the susceptibility of different types of organisms. I've just chosen the susceptibility to levofloxacin for this table. And you can see that if an organism is, especially Staphylococcus, is methicillin resistant, whether it is Staph aureus or whether it is coagulase negative staphylococci, it develops resistance to other antibiotics as well, including levofloxacin. So methicillin resistance actually renders an organism multi-drug resistant. MIC-based data, which we analyze for in our institute, gives a similar kind of a picture. Bhupesh Bagga had published that decreased susceptibility to quinolones in methicillin-resistant Staph aureus is always seen. And this diagram shows what exactly I just told you, so I will not repeat. We had seen in the other study. The Staphylococcus are more resistant, whereas pneumococcus, that is Streptococcus pneumoniae, the susceptibility is high. It helps really to have surveillance methods like we have in US and European countries. This kind of a surveillance activity is actually missing in India. And all the reports that we have are mostly done in different individual laboratories. Though ICMR has started a surveillance method on its website, ocular isolates are still not being really included in that. An effort was made by Donald Tan and his group, a big study which was done in 8 countries with 12 study centers in 2012 called ASIC study. Santen was one of the sponsors. So in this study, infectious keratitis isolates were all stocked, and they were studied for antibiotic susceptibility to a variety of antibiotics as mentioned here. And the organisms top were against Streptococcus pneumoniae and in gram-positive, and Pseudomonas aeruginosa in gram-negative. I collected data from Arvind Eye Hospital, and again you find the same thing. Staph is showing resistance. This is susceptible. The graph is showing susceptible, and you can see the lines are lower than the green one, which is Streptococcus pneumoniae. So susceptibility of pneumonia is across the world and across several years has remained susceptible. And the story about Staphylococcus is same, susceptible to cefazolin and vancomycin, but not to others. And Streptococcus pneumoniae, I already spoke about. So LVP data and Arvind data was similar. I did find a very big difference in Pseudomonas from Aravind Eye Hospital and from ours. You can see most of the Pseudomonas from Aravind are actually susceptible, 90s in there, except for the cefotaxime. But the ones from LV Prasad showed resistance quite a bit. We also have studied endophthalmitis isolates and published 25 years data and showing the trend of the microbiological spectrum and antibiotic susceptibility. There is a dip over the years in bacterial infections. And when we look at the antibiotic resistance, there is an increase in resistance to almost all antibiotics over a decade. And most notable was resistance of gram-negative to ceftazidime, which is a drug which is given intraocular for the treatment of endophthalmitis. And this resistance is actually very, very meaningful and very worrying for the retina surgeons. However, things are not so bad as they look in vitro testing. There is some hope when this paper, which was done for a very long time, over 30 years, has shown that in a 90-60 rule in drug therapy, it says that in vitro, if an organism is resistant, there is still a chance of 60% that it will respond in vivo. And if it is susceptible, 90% of the time it will definitely respond. So I think in clinical scenario also one sees that, and therefore we need not be very much taken away by the in vitro results. However, we need to have some knowledge of that, and this is a panel of antibiotics which in our laboratory we test both by disc diffusion as well as by e-test for MIC. Here is to show you how the disc diffusion assay is done. You have a plate with bacterial spread over it, and then you put discs containing antibiotics, and it shows after growth a zone of inhibition. In e-test, it is similar, except that we have gradations of the antibiotic, different concentrations, and it shows a teardrop kind of a zone of inhibition. Another one we use is Vitek. This is the automated method of testing antibiotic susceptibility. I would like to really describe what we mean by MIC, because the audience is going to hear today a lot of MIC, MBC, and other things. So here you see there are tubes containing different concentrations of the same antibiotic, and the bacteria has been added. And this is the lowest concentration where there is no growth. The white is growth and gray is no growth. So the least concentration or lowest concentration of antibiotic which does not show growth visibly to the eye is called minimum inhibitory concentration. But when you take cultures from here, from these concentrations, it is possible that there is live organism in that which is growing on the plate, but at a slightly higher concentration there will be no growth. And so this is the concentration which is called a minimum bactericidal concentration. So that's the difference between MIC and MBC. How do we know what zone of inhibition is susceptible, intermediate, or resistant? It all comes from a book published by CDC, and when you read any publication, you read Clinical and Laboratory Standard Institute, that is CLSI guidelines. So these are the books we follow. And it gives you all the zone of inhibition to be recorded as susceptible, resistant, as well as for MIC, what microgram per ml is MIC is susceptible and what is resistant is mentioned in this. Unless this information is available in this book, we cannot interpret our antibiotic susceptibility test that we do in the laboratory. How is all this relevant to therapy? Now, pharmacokinetic considerations make a recommendation for dosing that should exceed MIC. If it is more than MIC, it's likely to kill the organism. But you can see in this graph that it is not one particular place which is the MIC or that concentration. There is a window here. And this window is called the selection window. So there is a range of concentration, the bottom of which is MIC, and the upper level of that is called mutation prevention concentration. So if the drug dosage is within this or below this, there is going to be mutation. Below this, there will be low drug concentration, during which time the organism will multiply, and every 10 to the power 7 it multiplies, it gives rise to mutation. But even above MIC, until it reaches mutation prevention concentration within this window, in fact, there is an enrichment of resistant mutant subpopulation. What gets selected, what gets formed here gets selected here. And so you get more of selection of the mutants in this range. So it's very important to understand the mutation prevention concentration of a drug. Now I've already defined that for you. The drug concentration at which no bacterial mutant is recovered when there is a population of 10 to the power 10, that is called mutation prevention concentration. In fact, there are papers which give very simple ways of measuring that, and therapy at this level is likely to prevent development of resistance. I think we are going to talk more in this meeting about this aspect. Now, understandably, there are health agencies are worried about antibiotic resistance, hence antibiotic policies are required to be made by the hospitals. And it is very disappointing when NABH, which goes around looking at different hospital policies, it has come out with this statement that though there is antibiotic policy on paper in most of the hospitals, the compliance is extremely poor. It is necessary that every hospital tests its own patient population, isolates, and comes out with a policy based on what type of antibiotic susceptibility exists in their hospital patient isolates. So what are the reasons for development of drug resistance among ocular pathogens? It is said, and ophthalmologists try to take or hide behind the fact that they are not the ones who cause resistance. It is the systemic infections which are loaded with the antibiotics, and that leads to resistance. Overuse of antibiotics in animal feeds, in agriculture, all they are blamed. But there are papers now which have shown that overuse of topical antibiotics in the eye can lead to development of resistance. And here is a very nice paper which has shown in a control study that if you put fluoroquinolones, how the resistance of the staph epidermidis in the conjunctiva can go on increasing in the eye. The normal flora can go on developing antibiotic resistance. So I think there is time for mutation prevention strategies to be adopted in ophthalmology. Ocular drugs need to be tested for MPC, and the MPC may help to determine whether the drug concentration achieved in ocular tissues following a conventional dosing is sufficient to prevent the growth of the first step of mutation. And here is an example of MPC 90 of gatifloxacin is fourfold lower than MOXY. So that in a way speaks about the higher efficacy. How do we limit? I think it's very obvious that use antibiotics only for bacterial infections, identify causative organisms, use the right antibiotics, not broad spectrum, and finish the full course. No tapering. That's very, very important. Tapering will lead to the lower concentration, more multiplication, and more mutations. Do not use for viral infections. And I hope I have set the stage for the next talk on pharmacology of antimicrobial therapy in terms of pharmacokinetics and pharmacodynamics, very important for this meeting. I thank you so much for your patient hearing. I don't know if I have taken more time than given to me. Thank you so much.
Prashant, you have to unmute yourself.
Thanks, Savitri, for a wonderful overview of the epidemiology, drug resistance, the way we study the in vitro susceptibility, and how do we interpret results. I will now like to invite Dr. Shail Vasavada to give his talk on rationale of selecting an antibiotic, what matters the most. Dr. Vasavada is a senior consultant at Raghudeep Eye Hospital in Ahmedabad. His primary focus has been on cataract, refractive surgery, and corneal diseases, and he has a lot of experience with the use of antibiotics in cataract surgery, and I'm sure he will be giving a good overview of the rational use of antibiotics. Over to you, Shell.
Thank you very much, sir, and thank you to AIOS for this platform. It's almost impossible to follow Madam in this topic particularly, but I'll try to share my very limited understanding of this topic of selecting the correct antibiotic and the rationale for choosing a particular antibiotic. So I think we all understand that antibiotics in ophthalmology are administered through different routes, and more the first two, that is the topical and the intracameral or intravitreal, are the ones which are most relevant, as has been realized that systemic antibiotics have a fairly limited role except in very special situations, and we'll be concentrating more on the topical antibiotics. So I think there are a few principles that we need to keep in mind before we choose an antibiotic, and just not rely on the brochures that the companies come up with, because if you go to the brochure of each company, you'll find this is the best drug in the world to be used. So I think we need to look at the mechanism of action that the drug is acting on. We need to critically review the peer-reviewed literature and the susceptibility pattern, particularly in the region that we are practicing, like Dr. At the LV Prasad Arvind group, they've all shown quite a few differences than what will be published in Western literature. And it's also important to note the type of disease that you're treating. The involvement of the different ocular structures may coexist, and it may not be limited to one structure of the eye. And the reason why we want to choose a correct antibiotic is that because if we don't treat the infections in time, keratitis can easily spread into endophthalmitis, and can cause a loss in vision with the increasing drug resistance. Over a period of time, Western literature has shown that the gram-positive organisms are the most common organisms causing infections. Uh, we realized that in the Indian literature, until few years back, it was mainly the gram-negative that were being considered to be more causing the organisms, causing the infections, almost a 50-50 spread. However, like Madam showed, the publications, recent publications from Madam at the LVP group and other groups have shown that again the gram-positive infections are increasing as far as Indian bacterial isolates are also concerned. And also fungal infections are more on the rise compared to the gram-negative organisms. Another similar study from the Delhi infectious keratitis study also showed similar patterns of infection spread. Out of the various mechanisms, why is it important to know that a drug can act through different mechanisms? Because you want a drug which acts more often than not on the more important drug pathways, which are likely to affect or kill the cell organisms much faster and in a more efficient way, out of the several ways in which it can act. And for that, like Madam suggested, the knowledge of limited knowledge for us as clinicians of pharmacokinetics and pharmacodynamics is useful to make the decision. I think if we broadly separate the pharmacokinetics and the pharmacodynamics, from what I understand, pharmacokinetics is related to the body or the host. That is the absorption, distribution, metabolism, excretion of the drug, how much it penetrates in the eye, the maximum concentration, the amount, the area under the curve it stays for the X number of hours, so on and so forth. And pharmacodynamics is basically the drug itself, the properties of the drugs, that is the biological effects, the therapeutic effects, whether it's a single spectrum acting, broad spectrum acting, the minimum inhibitory concentration, and so on and so forth. And as far as the host bacteria interaction goes, it is this pharmacokinetics which relates to the host, and the pharmacodynamics that relates to the bacteria. The interaction between the two actually determines how this drug is going to act. Most of us as clinicians until so far, like Madam highlighted, have known only MIC, and the moment some representative would come and say that this has the highest MIC, we feel this is the best drug. And it's partly true as well that the antibiotic with the lowest MIC value is considered to be the most potent. So lower the MIC, it means lower the amount of drug concentrate required to kill the maximum number of bacteria. And amongst the several studies, it has been shown over a period of time that the fourth generation fluoroquinolones have seemed to have a very good MIC potency against most of the common organisms, and not just the gram positive, but they have very good susceptibility even to the gram negative organisms. So, it covers the almost entire spectrum of infections that all of us are seeing. The fallacy of using only the MIC or the minimum inhibitory concentration data, like Madam suggested, is that it gives only the potency of the drug. It doesn't give any information regarding how long this drug is going to stay there and how long it's going to act, for how many hours it's going to act in the body after a single dose, and how the rate of bacterial killing is going to be affected by the drug concentration, by either increasing it in the target tissue or by decreasing it. So therefore, there are certain ratios which combine the principles of pharmacokinetics and pharmacodynamic, known as the PK/PD indicators. And the three of the most commonly used for studies are the percentage of time of the free drug that remains above the MIC over 24 hours, the ratio of the maximum concentration of the drug to the MIC, and the ratio of the free drug area under concentration time curve to the MIC period. So, Madam very nicely highlighted the graph to show the importance of the MIC and the area under the curve, and the maximum concentration, the peak concentration that is achieved in the target organ. And it has been shown that the ratio of the area under the curve and the MIC is related mainly to the therapeutic effect, meaning higher the ratio, higher the therapeutic effect. And the ratio of the concentration peak to the MIC it determines how fast the organism is going to develop resistance to that particular drug. So you want an enhanced area under the curve and MIC ratio. That means that that drug is going to have higher therapeutic efficacy. At the same time, you also want a higher Cmax, that is the peak concentration to the MIC ratio, which means that it is going to reduce the chance of resistance developing to the organism, to the particular drug that you are using. And fluoroquinolones in general have been shown to exhibit concentration dependent bactericidal activity. And therefore, most of the fluoroquinolones, particularly in the fourth generation, have been shown to have maximum tissue concentration and therefore higher efficacy of the antibiotic, and less development of resistance compared to the other antibiotics. But like Madam highlighted, the trends and things are changing in the last few years. I think the choice of antibiotic also depends on the site and severity of the infection. So you need to look at whether it's only a corneal involvement, or whether it's already has significant anterior posterior segment or scleral involvement. How much is the corneal involvement? Is it a small central single punched out ulcer? Is it spreading up to the limbus? Is it involving different areas? And like we said, that do you even consider strong antibiotics, or very selective, very extremely selective recalcitrant bacterial membranous conjunctivitis, which do occur particularly more in the pediatric population from time to time. If you have infection which is not only in the cornea but also spread into the structures inside the eye, it's important to also know the aqueous humor penetration or intraocular penetration of these drugs. And this was a study published way back in 2013 in Cornea, in the journal Cornea, I mean, which showed that the levofloxacin as well as the moxifloxacin both had good aqueous penetration after topical instillation of the drug. However, the higher concentration levofloxacin showed even more aqueous humor penetration compared to the 0.5% moxifloxacin. And another recent article just published a couple of years ago was studied the aqueous humor penetration of high concentration levofloxacin and moxifloxacin in patients undergoing cataract surgery. So these were not infected patients, but samples were taken amongst these patients who were randomized to both the drugs, and it was found that the higher concentration levofloxacin achieved higher aqueous humor concentration. Coming to which drug to choose, and we've all learned from the LVP, Arvind, Ames, everyone, that it's usually in the very severe infections, most of the organisms, particularly if they are drug resistant, don't respond to the commercially available eye drops, and therefore we have all learned right from our postgraduate days of choosing fortified antibiotics, that is antibiotics made from the injection drugs or the systemic drugs by mixing them into distilled water. So in real life, it does work very well in institutes, in training centers, but in a single standalone private ophthalmic practice, fortified antibiotics do have a lot of challenges. First is preparation and contamination. That is the major risk factor. Second is because these drugs do not have preservatives, you don't know how long they are going to stay effective and not get contaminated by other structures. They need refrigeration, and they need frequent change of the drug and frequent making of the drug time and again, every 3 days or so. Whereas if you have a drug which would be as efficacious and still be commercially available in a drop form like normally patients and we as ophthalmologists are used to, it makes life very simple because it can be bought across the counter from a pharmacy. There are less chances of contamination because the bottle, the preservatives, everything has been designed to prevent that. And there will be no need for frequently changing the drug or frequently making the drug every 2 to 3 days or so. The AO in 2018 reported that the commercially available fluoroquinolones, the fourth generation, have fairly high effectivity rate in treating most of the bacterial infections, almost as equivalent to fortified eye drops. So I think to have a commercially available eye drop which would reduce the need for making fortified antibiotics for a standalone ophthalmic practitioner, I think is very, very important. Antibiotic resistance, like Madam suggested, I'm not going to go into the details, but as was correctly highlighted, the most common reason which we like it or not is us as ophthalmologists, because any red eye now, you see the prescription that the patient carries, there's always be a moxifloxacin in it. Whether it's a viral conjunctivitis, it's the season for viral infections, but still they'll be having a moxifloxacin. Whether it's just irritative dry eye, they will still be having moxifloxacin. And I think antibiotic steroid eye drops combinations have proved lethal over the last few years because, first of all, you don't need antibiotics for as long as the steroids, and you need to taper the steroids, but you don't need to taper the antibiotics. So I think these two is something that we as ophthalmologists need to take responsibility in trying to reduce the misuse. And another important point that most of us hesitate to talk about is the quality of the drug, because it's very, very important how what actually is in the drug is actually what is written on the label. So a drug which is effective needs to be of appropriate quality, appropriately made. And that brings us to the topic of branded versus generic. It's important for the audience to understand that generic is not just something which is made by a local company. So you have three categories amongst this. First is the innovator drug. That is the company that actually makes and innovates the drug. The second are what we call as branded generics. So once they are off patent, any company can make it and sell it under their own label, which we commonly see in India. And the third are true generics, where actually on the label you won't have any company name or anything on that. So most of the times what we confuse with generics are actually branded generics. And several articles have shown over a period of time that the drug concentration and the availability of these true generics is questionable in more than one situation. And therefore, I think selecting a cost is definitely a major issue and should be kept in mind, but that should not be the only criteria when we choose the quality of the antibiotic. So having all gone through this, which is the antibiotic of choice, I think it varies, like I said, from all of the factors. And we want a drug which acts more, has faster action, less side effects, and more importantly, low resistance. So I would like to conclude that we need to, make our choices based on evidence, on the literature that all of these brilliant, great institutes are coming out with. Uh, we must acknowledge that the resistance to fluoroquinolones is of growing concern. So be careful and keep in mind when you prescribe a fluoroquinolone whether the patient actually needs it. Using more potent antibiotic formulations with the lower propensity of resistance may prevent less resistance from occurring less quickly. And the principles of pharmacokinetics, pharmacodynamics should be kept in mind before choosing a particular antibiotic. So I thank you all for your patient listening. And madam, my apologies if my concepts have not really been as thorough as yours. Thank you.
Thank you, Shal. I think that was a very nice presentation. And I agree with you completely. For any one of us, it is very difficult to follow Madam because her presentations are so good. But you did a great job. And I think with this, we move to the next presentation, which is going to be by Professor Rajesh Sinha. And it's a pleasure to introduce him. He's the treasurer of All India Ophthalmological Society, working as professor in the cornea cataract and refractive surgery services at RP Center, has more than 325 publications to his credit, with 4 educational books. He's been the past editor of Delhi Journal of Ophthalmology, and he has to his credit he's been a part of several multicentric FDA clinical trials. He's presented at various international and national platforms and has numerous awards to his credit. To name a few, the Achievement Award by the American Academy of Ophthalmology, the Achievement Award by the Asia Pacific Academy of Ophthalmology, the SAO Excellence Award at SARC Academy of Ophthalmology, and several of the awards at the national platform as well. He's also the secretary of the Indian Society of Cornea and Keratorefractive Surgeons and the treasurer of Eye Bank Association of India. And I think he's going to give a talk on the practical tips of how to diagnose a case of bacterial keratitis, microbiological investigations, and antimicrobial therapy.
Uh, Thank you, ma'am, for introducing me. I mean, it's really it has been a great association with you for the last so many years, and today also I would like to thank you for a nice and kind introduction. I would like to thank AIOS and Santin for having me in this webinar, wherein we have such wonderful speakers and 2 stalwarts as moderators. I would like to present on management strategies of bacterial keratitis. Now, the approach towards management for any infectious disorder is to assess the severity first. And it is not just to know the severity, but as we all understand that, severity, it guides our treatment as well. The biggest thing, the most important thing that we have to do in infectious or microbial keratitis is to identify the organism, either clinically or by investigations or by both. And then only we can have an appropriate antimicrobials for eradicating the organism. And while treating, sometimes we overshoot our aim. We give a lot of drugs, so we have to minimize, we have to be judicious, so minimize drug toxicity as well. And if needed, if nothing is working and the cornea is perforated, then we have to resort to some surgical management. Now, assessing the severity is very important. It is not just theoretical thing that we have to assess and we have to know whether it's a mild ulcer or a moderate or severe, but the treatment also depends on it. And many of the cornea surgeons believe that, although there are studies comparing comparable results of monotherapy with combination therapy, but we use monotherapy in mild ulcers, but in moderate and severe we use combination for therapy of fortified antibiotics. So grading of corneal ulcer is important, clinically very much relevant in terms of management of ulcer. As I said earlier, that identifying the organism is actually the key, because we have to use the appropriate antimicrobials, and that can be ascertained by knowing the history, by having the history, associated event, whether there was a trauma with any specific thing, whether there was a history of any surgery. So all these factors, they guide us to a great extent to clinch the organism. Of course, by clinical examination, we can assess, we can have an idea of the organism if the patient comes in an early stage, but once it is very advanced, it becomes difficult. And of course, by investigations, we confirm the type of organism in majority, of course, not in all. Say, for example, if there is a post-LASIK keratitis, and the keratitis has come up in a couple of weeks, the first thing that comes to the mind is atypical mycobacterium. And this is why we all discuss and we do the literature review, because you immediately start thinking, because thousands of keratitis reported in the literature, if they have shown that this is the most common organism or the typical organism, then we have to investigate keeping this in mind and have our direction in keep ourselves in that direction. So as I said, atypical mycobacterium or staphylococcus or pseudomonas, or there can be polymicrobial infection as well. And this is what has been reported in the AACRS survey. Now, if we have an event of a surgical event of an intracorneal ring segment, and there is an infection in that, if there is a keratitis, then again, we would like to know what are the organisms that affect more. And in literature, it states that the gram-positive cocci are the most frequent organisms causing post-intact keratitis. So we have to take ourselves in that direction, investigate accordingly. Infection after CXL has been reported with many organisms, and we have to keep investigating for all these organisms. Post-penetrating keratoplasty, it's a gram-positive cocci that is most commonly implicated. We also have done a few studies in that. And so we direct ourselves in that direction. Infectious crystalline keratopathy, post-lamellar keratoplasty, post-LASIK, maybe because of alpha-hemolytic streptococci or staph. Post-lamellar keratoplasty keratitis, like post-DSEC or post-anterior lamellar keratitis. Anterior lamellar keratoplasty keratitis. It is also called interface infectious keratitis or a sandwich infectious keratitis, because it is like a sandwich. We have the corneal tissue on two sides and infiltrate in between. And mostly it starts in the interface, starts from the donor tissue and moves towards the host. And the organisms that have been reported in a couple of studies which have done, this is a review article by Fontana et al., and they have found out that in majority of studies, it's the fungal infection that is more common. Apart from that, actinomyces, mycobacterium, Klebsiella, and staph have been found to be the causative organism. And donor rim culture has given the maximum yield as far as organism is concerned. If it's an immunocompromised individuals, like HIV positive individuals, you can have polymicrobial infection, you can have staph, you can have fungal, particularly in immunocompromised, it is Candida. And we reported this series of patients of post-antiretroviral therapy where the patient developed ocular surface disorder, and there was infection, keratitis, and we found out that in majority of cases, it was staphylococcus and acanthamoeba. In bullous keratopathy, since there is a reduction in local immunity, we can have infection by commensals, and we can have infection by streptococcus or staphylococcus. We also use bandage contact lens. That can also be a factor. Long-term use of bandage contact lens can lead to infection. Contact lens induced infectious keratitis, if it's, if the patient gives a history that he uses contact lens, he slept with contact lens, he swam using, he went into the swimming pool with the contact lens on, we can suspect these organisms. If it's a very, very rapid, course with ring ulcer like this, it can be Pseudomonas. But if it's a slightly lesser rapid course, again having ring ulcer, etc., one can think in terms of acanthamoeba. So Uncommon organisms like staph, fusarium, etc. can also cause infections. So we have to direct ourselves in these directions. So that is the reason why the event and the literature search gives you some idea that you have to keep your direction in this line. Then clinical diagnostic clues are also very useful. Like gram-positive cocci, they typically produce localized round or oval ulceration with distinct borders, while gram-negative organisms, they have some edema surrounding the ulcer and they have ill-defined borders. So this gives you some idea that probably it is because of gram-positive or gram-negative organism. Pneumococcus can give rise to a serpiginous ulcer. If there's a serpiginous ulcer, you can think in those directions. Of course, AC reaction is quite high in that. Pseudomonas will have ring infiltrate, can have very rapid course. There is stromal melting. Also, it's mainly because it also releases exotoxins, which release collagenases, and that causes stromal melting. So Pseudomonas can give rise to a very fast perforation of corneal ulcer. Nocardia is a little indolent. It simulates fungal, can give rise to a wreath-like pattern or a cracked windshield appearance. So if we have this kind of these pictures, then we direct ourselves and investigate accordingly. Further, microbiological investigation is the key because it actually gives you the proper proof that this is the organism. Sampling of the organism, sampling of the tissue can be done by corneal scraping, by AC tap, by vitreous tap, by punch biopsy, by suture biopsy, and you can do various stains to identify the organism, whether it's a gram-positive or a gram-negative, then various cultures wherein we prefer doing direct plating to the culture media. Scraping is usually done under topical anesthesia, except if it's a very small child wherein we require sedation or general anesthesia. And as far as instrument is concerned, we use Kimura spatula or surgical blade number 15 for scraping. We use various stains, the gram stains for knowing the gram positive or gram negative organism. We can use acid fast stain for these atypical organisms. Then bacterial cultures can be done on blood agar, chocolate agar, and direct plating is preferred. Biopsy can be done if there is culture negativity on 2 or more than 2 occasions. Now, why culture becomes negative? It can be because of sterile ulcer, or there is a prior partial antibiotic treatment, and that is one reason. So we have to stop the antibiotic treatment for 24 hours and then do a scraping, or there's inadequate sampling, or there can be improper selection of the media or incubation, or there is false interpretation of data. And if at all we have more than 2 times negativity of the scraping, then we may have to do a corneal biopsy by using dermal trephines, and we can get a tissue for corneal biopsy and get the appropriate organism detected. Now, once we detect the appropriate organism, we have to do the drug therapy. As I mentioned earlier, the preferred choice is a combination therapy of fortified antibiotic, fortified cefazolin 5% and tobramycin 1.4%. The gram-positive organisms are taken care of by cephalosporins, and the gram-negative organisms, actinomyces, atypical mycobacteria, etc., are covered by aminoglycosides. Monotherapy is also useful. As I said earlier, fluoroquinolones can be used, the newer generation. They are effective against Pseudomonas as well. And there are a couple of studies which have compared garifloxacin and moxifloxacin with combination therapy of fortified drugs, and they found it to be comparable. However, there's a general consensus amongst most of the ophthalmologists and the cornea specialists that if it's a mild ulcer, less than 2 millimeter of ulcer, we can go ahead with a fluoroquinolone. But if it's a moderate and severe ulcer, we prefer using combination therapy. Now, currently, we are having higher concentration of fluoroquinolones like 0.5% GATI or 1.5% levofloxacin, about which we will be discussed in subsequent talks. So they are quite effective in moderate and severe ulcers as well. In post-LASIK keratitis, apart from the routine treatment that we follow for any bacterial keratitis, flap amputation is something which is required in order to have a good resolution of the keratitis. And for atypical mycobacteria, amikacin 2.5%, clarithromycin 1%, or even the newer generation fluoroquinolones can be effective. In post intracorneal ring segment keratitis, if it occurs, say, a week or 10 days after the ring segment implantation, and if it has started from the area of the suture, which I had shown in the earlier picture, then we can remove the suture and send it for culture. That will help us to know the organism. Ring segment removal can be avoided in some cases by doing the channel irrigation, but in many cases we have to remove the ring segment if it doesn't respond, particularly if the infiltrates are present in the bed of the ring segment. And these are quite severe, and such cases, if delayed, may require even therapeutic grafts in subsequently. Post-lamellar keratoplasty, post-anterior lamellar or DSEC or a DMEC, which is interface or a sandwich infectious keratitis. In that, we have to give combination topical antimicrobials, and if it's a fungal infection, then we have to give systemic antifungals. But medical treatment alone is not very much successful in majority, and we have to intervene surgically. And the minimal that we have to do is to remove the lenticule first, because most of the times it comes from the donor lenticule. So you have to remove the lenticule, and then intracameral or intravitreal or interface or intrastomal antimicrobials can be used to look for the response. But in many of the cases, if there is a marked infection, then excisional therapeutic PK has to be done in order to get a good response. If it's a keratitis, which is in the healing phase, then we have to reduce the frequency. We have to lessen it in order to, we don't have to taper it, but we have to abruptly reduce it in order to reduce the toxicity of the drug. We may add preservative-free lubricants in order to improve epithelialization and reduce supportive therapy to reduce drug toxicity. Steroids can be used once the infiltrates have started reducing, because we have to be very careful in using steroid, very judicious. If we use it excessively, it can cause stromal melting, it can cause a recalcitrant infection. So we have to be judicious, we have to be sure that the infiltrates are reducing, and then we use steroid to reduce it further, to reduce the inflammation. Systemic antibiotic is preferred when there is perforation or impending perforation, or where there is scleral or limbal involvement, or where there is virulent organism. And the drugs do require change if there is no response of the initial treatment and the culture sensitivity shows that the bacteria is sensitive to some other antibiotic. But even if the culture sensitivity is showing otherwise, as ma'am was also mentioning, Dr. Savitri was mentioning, that you can have a difference in the in vitro in vivo sensitivity. If the sensitivity is there, if the ulcer is responding, then we don't have to change the antibiotic. The progression of ulceration and perforation is basically due to resistant strain or virulent organism or inappropriate medication, or there's poor compliance by the patient, and if excessive steroid drops have been used early. And if there is a small perforation like this, or if there's an impending perforation or a fistula, then which is less than 2 millimeter, we can use a small droplet of cyanoacrylate glue. We can use a filter paper over it to have a controlled spread of the glue, and then we can put a bandage contact lens over it, and that will work quite effectively. But if the perforation is a little bigger and of this size, wherein the glue is not going to work, then we have to do a patch graft. And once we have done a patch graft, after that also we have to continue the antibiotic therapy in order to maintain the response and in order to have a proper resolution of the drug. These are some of the post-op pictures. And if the perforation is central, if it's a large perforation, large ulcer, then we have to do a full thickness therapeutic graft. And we have to ensure that the infiltrates are completely removed, not only from the cornea, but also from the anterior segment, from the anterior chamber. And we have to be careful in maintaining the anterior chamber by use of viscoelastic, so that because there is risk of peripheral anterior synechia formation in these cases and secondary glaucoma because of a high inflammation. So, and for the same reason, we prefer using a higher graft force disparity of 0.75 or 1 millimeter instead of 0.5 millimeter when we are doing therapeutic keratoplasty for a perforated corneal ulcer. So in conclusion, bacterial keratitis is an ocular emergency, and we have to be very meticulous but very fast in our approach towards diagnosis and management. The key to management is to detect the infective microorganism, and aggressive and early treatment is important. And if things are not working, then sometimes we do have to resort to surgical management in the form of in the form of cyanoacrylate glue or patch graft or therapeutic penetrating keratoplasty. Thank you very much for your patient listening.
Thank you, Professor Rajesh Sinha. It was really a good talk about the overview on the management of microbial keratitis, especially the bacterial keratitis. It is now my pleasure to invite Professor Jodhbir Mehta to deliver his talk on the promise of high concentration levofloxacin 1.5%. Again, I think Professor Mehta does not require any kind of introduction. He is professor at the Singapore National Eye Center, um, um, and also faculty at the Duke University and Singapore University collaborate. He has enormous publications and about 45 awards. His primary focus of work is on corneal endothelium and corneal transplant. He has done extensive work in the field of newer antibacterial substances and antibiotic resistance. So without taking much time, I will now like to invite Professor Mehta to deliver his talk.
Thank you, Prashant, for the kind invitation. So I'm just going to be sharing my slides. Okay. Let's go to full screen. Okay, is that okay?
Yeah, that's fine.
Great. Okay. So first of all, I'd like to thank AIOS for this kind invitation to partake in this great symposium with all these great speakers. And we're really talking about an important topic, I think, really, which is looking at the effect of bacteria and bacterial resistance. And my talk is going to really focus on the promise of high concentration levofloxacin, and the previous speakers have sort of alluded to some of the issues that we're all facing when we're dealing with these problems clinically. These are my financial disclosures pertaining to this talk. So we know antibiotics can be divided up into two broad types. One is bactericidal and one is bacteriostatic, and you can see them both here on the left-hand side. And how they basically prevent the bacterial, the organism from replicating, depends on basically their mechanism of action. And this is either related to this function on the cell wall, or it can be related to the protein function, such as on the ribosomes, or it can basically be function related to DNA replication. We know that fluoroquinolones particularly basically affect on DNA gyrase and topoisomerase type 4, and they inhibit basically DNA replication. So there is then subsequently no protein formation, and there's no subsequent bacterial replication downstream of this TARG. And over the years, we've seen an evolution of fluoroquinolones from the first generation all the way to what we consider to basically be the fourth generation. And you've heard some excellent talks about drug resistance profiling. This has really occurred between the second and basically what we consider to be the third generation. And there's several ways in which resistance has occurred, as Professor Sharma talked about. And this can be related to alterations or mutations in the DNA gyrase, and you can have an effect on the outer membrane of the cell, so it can affect the permeability itself, and this can affect the efflux mechanism of how effective these antibiotics are. And these are some of the mechanisms in which resistance can basically form. If you look at levofloxacin in particular, and you compare it against the other generation of fluoroquinolones, and you're basically measuring the concentration in the aqueous, you can see levofloxacin offers one of the highest concentrations within the anterior chamber, showing you the efficacy of its penetration. This is also basically shown over here, comparing to ofloxacin and ciprofloxacin, measured in the cornea and also basically in the aqueous, where you can see the concentration and levels are between 1.7 and 2.7-fold greater penetration. And this is, of course, important if you're dealing with corneal diseases, as we've heard from Rajesh talking about bacterial keratitis, but likewise also if you're dealing with anterior chamber inflammation or very severe diseases that have already penetrated into the anterior chamber, where you want to basically get good aqueous concentration as well. The drug itself is basically sensitive over a whole range of different diseases, so pretty much all the ocular surface and adnexal inflammatory or bacterial basically diseases. And over several studies, they've shown it to be quite a good efficacy rate over several studies have been done over different time periods. When you look at the different strains, of course, you've had previous speakers talking about the importance of knowing the strains that you're basically dealing with. Post-market surveillance using levofloxacin has shown good, basically, efficacy rates to staph, strep, and also basically enterococcus, and also basically with other gram-negative organisms. But you'll see some of the gram-negative organisms, such as Pseudomonas, for example, are lower than what we're able to achieve with the gram-positive organisms as well. Adverse effects, of course, are important to understand. They're generally quite low with these antibiotics because this is primarily a preservative-free formulation. And if you look at the issues with drug side effects, they're mainly dependent either to gastrointestinal disorders from systemic absorption, so this can be reduced by punctal occlusion, or basically related to local eyelid disorders, typically eyelid itching or basically blepharitis. One of the other issues that's important to consider, especially as ocular surface or anterior segment surgeons, if we're doing penetrating keratoplasty, is the effect on epithelial growth. And you can see from over here that you can see when you're looking at the viability of your epithelial cells, when you're comparing basically levofloxacin over here on the right-hand side, this is 0.5 levofloxacin compared to control group compared to Cipro. Levofloxacin offers one of the highest levels with respect to viability of human corneal epithelial cells. And this is important when we're considering epithelial regrowth, say after penetrating keratoplasty or after DOG, when the new epithelium of the recipient cornea is growing on the graft tissue. This is shown in another comparison over here, where you're comparing levofloxacin compared to moxifloxacin, typically postoperatively. Cell viability over here is in the y-axis, and you can see this from 30 minutes over to 24 hours compared to basically the control group, and this is showing you in a tabulated form. And you can see the viability of human corneal epithelial cells after 24-hour exposure to antibiotics is 62% with levofloxacin, but only 5% with basically moxifloxacin. And again, like I said, if you have a patient undergoing surface ablation therapy, where obviously the epithelium has been denuded and you want the epithelium to grow back quickly because you want to reduce the rate of infection, then of course you want something that's going to aid your cellular migration as opposed to inhibit it itself. And likewise, when you're doing migration assays, comparing to control group on top, levofloxacin in the middle and moxifloxacin at the bottom, you'll see the differences with respect to percentage wound healing compared to levofloxacin compared to moxifloxacin. This is significantly different at 94% compared to almost 60% as well. Now, antibiotic development, as Professor Sharma basically showed, initially from the penicillins and up into the early development up into the 70s, has really undergone a void over the last sort of 20 to 30 years. And people have been looking at other ways or repurposing other drugs, particularly that have been used systemically, that may also basically be used for basic antibiotic therapy. Or one of the other things they've been looking at is looking at your natural defenses on the ocular surface with respect to developing a drug. And the reason why this has been a huge issue is actually, to be frank, drug development is very, very expensive. And we know the fact that the resistance patterns can occur quite early once basically a drug has basically been come onto the market. And because of those two things, a lot of companies are unwilling or they're hesitant to invest a lot of money in developing new forms of antibiotics. But from a clinical side, you can see from this diagram over here, when you're looking at percentage resistance patterns, and if you look at India over here in the red line over here, you'll see practically from a clinical standpoint, we're all dealing with high levels of resistance or bacterial resistance when we're seeing patients in the clinic. So we're stuck in this dilemma where the industries, they may be reluctant to actually develop new antibiotics because of the cost issue and bringing it to basically market. But from a clinical standpoint, we are basically having to face more and more patients who are basically getting more resistance to the current antibiotic therapy that we're basically looking at. Now, one of the things that some of the previous speakers have basically talked about has been the effect of this concentration. This is the PK/PD theory with respect to how levofloxacin 1.5% was basically developed itself. And as the previous speakers have mentioned, there are a couple of things to basically look at. One is the mean inhibitory concentration. And ideally, what you're trying to aim for is 10 times above this level, where you can basically kill all the organisms that are basically known to basically be present in the sample itself. And Professor Sharma nicely showed that on a Petri dish, where you can see the MBC showed there was no evidence of any culture at that level itself. So you can dose an antibiotic up to this level to basically ensure that they don't get resistance. But one of the issues when you do a high dose antibiotic is one, of course, is compliance. But the second is that can you actually get that concentration of antibiotic at that level in the specific tissue target? This is basically showing this a little bit more elegantly in a curve over here itself. And what I'm talking about is your Cmax. So this is your target concentration in the tissue of basically interest. This TAM, or time above the MIC, shows you the time at which you're at that, above that concentration with respect to the target tissue as well. And the administration dose is your Tmax, so it's the time it takes to actually achieve this level itself. And what we're trying to do is achieve such a high level of concentration in the target tissue that you're basically preventing any basically mutant strains being formed. This is also shown in this diagram over here, where you can see that there is a window period, as Professor Sharma showed, where you get what we call the mutant selection, basically window period over here. And if I show you this cartoon at the top over here, where you have a typical population of bacterial cells itself, and if you take the bottom curve at the bottom over here, you will see that this bacterial population over here is basically growing quite well because the antibiotic that's basically been used in this example over here is below the MIC. So this is typically below the MIC. When you go into the mutant selection window period, so you're above the MIC window itself, but you're below the MPC, which is basically the area in which you're going to basically get pathogen resistance or mutation resistance itself, you will see that your antibiotic is killing the sensitive bacteria. So this is in B over here. But the resistant organism is still going to basically be there, okay, because you're below this basically threshold. But if it's possible to go above this threshold, as I showed you on the previous curve over here, you can basically clear everything. And this is ideally basically what you want to achieve. So you need to have an antibiotic that has high penetration with respect to the tissue or target of interest, and ideally a broad spectrum activity, so it will have this effect on multiple different organisms. So the question is that this is the theory behind this. Is this basically what is achievable on a practical circumstance? So if we look at basically the concentration profile of the levofloxacin 1.5%, and we look in 3 target tissues, one is the cornea, one is the aqueous humor, one is the anterior vitreous. You see the levofloxacin over here is in blue, gatifloxacin is in green, moxifloxacin is in gray, and besofloxacin is basically in blue. You will see from all these diagrams over here that levofloxacin has the highest concentration in the cornea, it has the highest concentration in the aqueous humor, and it has the highest concentration within the anterior vitreous. So sure enough, after the time of installation, you do achieve the highest concentration with respect to the target tissue of interest that you basically want the fluoroquinolone to react. If you look at the concentration profiles and you basically compare single installation versus repeat installation, so this is basically one dosing compared to multiple dosing, you will see the effect on the concentration gradient. So of course, with multiple dosing, you get an increase of 2.5 concentration, so you get a much higher concentration of drug at the target site. And often that's why when we start off with some antibiotic therapy, often I'll ask the patients to increase the frequency of dosing with respect to the first few hours, so you can get a buildup of the concentration of basically the drug. So this is the repetitive installation basically bar over here, and this is higher in the levofloxacin 1.5 group compared to Gati, Moxi, and besofloxacin on this side over here as well. And this is cornea on the left and aqueous humor on the right-hand side. So what about in other basically tissues of the adnexus? So in the cornea, I basically showed you as well. This is comparing levofloxacin 1% to compared to levofloxacin 0.9% and 0.5%. So in the cornea, I've already showed you compared to other fluoroquinolones, but you'll see the same effect in other tissue of the anterior segment. So in the bulbar conjunctiva, in the palpable conjunctiva, and likewise as I've shown you also in the aqueous humor. So what you're getting in the cornea and also basically in the anterior chamber is also replicated in other dosing on the ocular surface as well with respect to the Cmax in tissue. And this study was basically done on rabbit eyes, which are very similar to human eyes with respect to their size of the anterior segment. If you look at basically the organisms and with respect to microbial activity, you'll see there is a wide range of microbial activity spectrum, both for gram-positive, gram-negative, and also basic anaerobics compared to other available fluoroquinolones on the market as well. And this has been also shown in several studies when you're looking at the range of the MIC concentrations, whether you look at MIC 50 or you go all the way up to MIC 90, you'll see low levels of MIC levels when you're looking at the gram-positive cocci. And likewise, basically, when you're looking at the gram-negative bacilli as well. And this has been shown in by several groups with several studies looking at various organisms as well. Now, From a clinical standpoint, when you start a patient on medication itself, obviously we want to know what is the response to action. In a study looking at 176 cases using levofloxacin 1.5%, you will see overall from initiation of treatment, about 67 to 2/3 of patients had a reduction in their symptoms basically by 3 days, and this was reduced to 96% by 1 week itself. Likewise, if you actually tested the ocular surface, so this is showing you the antiseptic or the antimicrobial effect on the surface tissue of interest, you will see that by 3 days, 95.5% of the bugs on the ocular surface were basically eliminated. So that you're getting a very high level of killing or therapeutic effects from the Cmax. So it shows you what I showed you with the Cmax earlier is not something in theory or what's been shown in animal studies, is also basically shown in clinical cases where you're getting a high level of basically Cmax with respect to what you're able to culture from the ocular surface. And this is by 3 days, you're getting 95.5% response. This goes up to 99.4% response basically by 1 week as well. One of the issues that you might think about, well, if you're using a higher concentration drug, is that are you going to basically get more side effects? And in this study, when you're looking at basically side effects from the drug, there were only 2.9% out of a total of 238 cases. 3 of these were basically related to eye irritation, 1 from basically a bad taste. So again, as I said, this could be eliminated with punctal occlusion, 1 from urticaria, and 1 basically from itching as well, which is a pretty low number in the large series that basically it would look like. So even though you're using a higher concentration drug, it doesn't seem to mean that you're getting a lot of adverse side effects locally on the surface of the eye. But one of the things that we worry about as corneal surgeons is that what is the effect on epithelial toxicity? Because again, if you're going to use this with respect to bacterial keratitis, if you have high concentration of the drug, it can actually delay wound healing. In this study that was done on monkey eyes, where you're comparing 3% levofloxacin compared to 1.5% levofloxacin over here in maroon, and this is basically the control group over here in gray, you'll see the 1.5% levofloxacin actually mirrors what you're actually getting in the control group over here itself with respect to the area of the epithelial defect. Once it's basically scratched from the ocular surface, it was almost completely healed basically by 2 days, over 90%, and 3 days, almost basically 100% healing effect on the surface itself. So by using a higher concentration, you are not having any long-term or any basically effect with respect to epithelial toxicity. So it's not basically affecting epithelial migration. And previously I showed you the comparison when you basically compare this drug compared to other fluoroquinolones that are available on the market as well. But one of the interesting points, and you know, we've mentioned this before in the previous talks as well, is about bacterial resistance. And this is one of the key things really about why you're trying to achieve this high concentration drug. The way this is basically tested is using a drug susceptibility population analysis, and this is using a tissue concentration simulation model. So you use a simulation model where you have bacteria basically plated on the concentration. You'll see the variation in the levofloxacin concentration over an 8-hour time period. And as the concentration basically fluctuates, this is trying to simulate actually putting a drop of antibiotic into the basically ocular surface itself. Then after 24 hours, you then take the bugs, and then basically you will culture them in different media and basically different concentration of levofloxacin. In this example over here, it's varying from 0, which is basically obviously your control group, up to basically 8%. Now, if your bacteria are basically developing resistance, then you would expect you get growth at higher levels of basically levofloxacin concentration in this basically plated media. So what did the results basically show from this study over here? So if you look at the results over here in 1.5%, this is basically in the maroon bar, and this is compared to 0.5%, which is over here in the pink bar over here itself. This is the negative control on the left-hand side over here, where there's no levofloxacin over here itself. So of course you do expect to see bacterial counts in this level over here, but you can see even at 1 times MIC all the way to 16 times MIC, there was little detection of live bacteria counting. And this shows you on the left-hand side over here, and also on the right-hand side over here is measuring the MIC concentration again from basically 1 to basically 16, where you can see minimal detection of basically any bacteria itself. So what it's showing you is that it's actually the bugs are not developing any resistance pattern when you're using this drug at this level of concentration. If you look at this basically compared to methicillin organisms, so that was basically gram-negative, now you're looking at basically gram-positive organisms, again with the same experimental setup. You're looking at basically the control group before exposure in gray bars, The pink one over here is 0.5% levofloxacin, and the maroon bar is over here is the 1.5% levofloxacin. Again, you'll see no generation of resistance with respect to the 1.5 levofloxacin group at all. And this is in a conjunctival concentration simulation model, and this is in a corneal concentration simulation model on the right-hand side. When you look at Pseudomonas, which is obviously a common cause of bacterial keratitis, especially in the Asia-Pacific region, so it's an important thing to basically for us to basically look at. Again, you will see that levofloxacin 1.5% solution is down over here, so there's no evidence of any basic development of resistance to the 1.5 levofloxacin solution, but there is some element of developing resistance if you're using the 0.5% basically version over here itself, and you can see the concentration of resistance goes up to almost 8 times the MIC concentration compared to basically baseline. So this proves that the thinking about the PK/PD is not only seen by what we're able to measure in the concentration where you are achieving the higher levels of Cmax, but also what we're seeing basically in a practical side when you're actually trying to see if there's any resistance profiling on the organisms. So I'm just going to share with you our experience of basically using levofloxacin on a couple of our patients that we've been seeing recently. This is a 17-year-old Malay girl, and I want to show you some examples of some of the uses of this antibiotic, especially when you're using multiple against multiple organisms. So she initially seen in one of our satellite hospitals with a 4-day history of redness. Notice on the cornea, you can see the scarring and basically this infiltrate over here. Visual acuity was 660. She had the central insulae scraped. This she was thought to be an atypical organism as well, and she had occasional cells in the anterior chamber. She had a 0.3 millimeter hypopyon, and she referred to SNEC from our satellite, and she started on fortified KEF and gentamicin. She developed some toxicity to the gentamicin, as you can see in the middle picture over here, and she was put on levofloxacin 1.5%. And she's a contact lens wearer, so we asked her to bring her contact lenses so we can culture her case as well. And by looking at the appearance over here, it looked a little bit unusual with respect to the way the epithelium had grown. So we felt that it's probably a multiple organism growth. We know this from the ASIC study, considering about almost 60% of the bugs that we basically cultured in the Singapore part were actually basically a multiple organism as well. And the idea was to basically review her again. We reviewed it in 2 days' time, and pain had basically settled down, visual acuity basically improved, hypopyon was basically better, as you can see from the bottom pictures. Now, interestingly, when we basically took the results of the scrape, you'll see here she actually had 3 organisms on one culture plate over here, so Pseudomonas, Serratia, and Stenophus nomus. And you can see basically the sensitivity patterns to basically the 3 bugs on this side over here. And then when we got one of the other culture plates back itself, you will see that she also had Pseudomonas and a Chromobacter. And we see a Chromobacter relatively, I wouldn't say very commonly, but I see definitely probably about almost a dozen cases a year. And typically, sometimes these are actually quite resistant to levofloxacin, and they often have to use a different drug, maybe it's even piperacillin, to basically kill the Chromobacter. But typically, we see it in a bit more immunocompromised eyes as well. So we added a bit of anti-inflammatory medication to the surface after about 4 to 5 days. Visual acuity basically improved to 612, and this is the last time basically where we saw her more recently. She's now up to 6.7.5. This is that 1 week review where she's 6.9, and we basically managed to treat her empirically now on this antibiotic, even though she had these multiple basically organisms grown from basically her ocular, from her corneal and keratitis. So this shows the benefits of having a broad spectrum antibiotic that's basically fortified, well, pseudo-fortified in the fact that it's commercially available, but it's giving you a high level of concentration activity when you're basically using it on the ocular surface with minimal toxicity compared to other fortified medication. This is the second case I'm going to share with you, which is a 58-year-old Malay gentleman. It's a 1 week history of basically redness. He's again a contact lens user. We had a lot of patients when we were in lockdown here who came back in with contact lens basically related infection. So you can see here the 5.5 millimeter lesion. His vision acuity was count fingers. He had an epithelial defect over this area and had an infiltrate with a small hypopyon on the surface. There was some differential diagnosis as possibly a secondary bacterial infection on a background of herpes. He was started on acyclovir, topical and oral, and also 1.5% levofloxacin to be used basically day and night. Now you can see basically from his microscopy, in fact, he had gram-positive cocci, gram-negative bacilli, and gram-positive bacilli as well from the microscopy result from his microscopy and culture. Now, interestingly, we actually didn't grow anything from his culture plates basically at all. So we're now treating him empirically, and often, obviously, we need to do this because just because you grow something from the microscopy doesn't mean that you're going to be able to culture anything. But 2 days later, his pain had basically got better. His epithelium basically started to heal over. We added in some anti-inflammatory medication as his epithelial defect was basically healing, and this is basically how he remained. We never really grew any basically cultures on the ocular surface. He's basically about 636 now, 624 on this side over here. We've trialed him with a contact lens, and basically once the scarring is basically settled down, we will put him for an anterior lamellar keratoplasty if he's unable to get any better visual acuity with respect to if he's using a rigid gas permacontact lens. But this shows you the advantage of having to treat somebody where you, even though you get something on microscopy, but you are unable to basically get it on the culture, which is something that we all face, especially in larger hospitals, that we have to basically go with our response on the organism, response on the eye, as opposed to what we can basically get from our culture results. The last case is quite an interesting gentleman who's a man with 48-year-old gentleman with G6PD. Now, most of you will know that G6PD is actually a contraindication to using levofloxacin, but there are variants with respect to the enzyme activity of G6PD, and typically the enzyme variant that we see in Asia is a little bit more, you have a higher chance of basically, you have a lower chance of actually getting anemic side effects from using fluoroquinolones, because especially if you're using basically topically compared to the Mediterranean version of G6PD deficiency. So he had a history of bilateral LASIK, and there was some question about a history of him. You saw a colleague of mine about a history of viral conjunctivitis, and he came back in with a 2-day history of a lid lesion and punctate lesion on his flap. He was seen again in one of our satellite hospitals. His visual acuity at that time was 6.6, and he was given Tobrex and Lotemax. Typically, he was given Tobrex because basically they were worried about him using G6PD. His drops were basically stopped because he basically ran out of medication. And 2 weeks later, he returned back to our main center with a reduction in visual acuity, and you can see the lesions basically on the surface of the eye. Typically, these punctate lesions are on the surface. At that time, the clinician that saw him felt this could be possibly herpes related. He was given acyclovir. He had a reaction to acyclovir, so we switched to Virgan. He was given a load of anti-inflammatory, and everything basically seemed to clear up with that. And visual acuity improved to 6.6, and he basically was left alone. He then reappeared 6 months later. So this was down during the circuit breaker period. So this is when I basically saw him, and he had a history of 4 days of basically pain. He had injection in the left eye, as you can see from the picture over here. And he had a redevelopment of these small little lesions basically on the surface, and he had follicles on his anterior chamber, and he had these basically small opacities that you can see clinically on his LASIK flap. Now, interesting, he has a history of keeping tropical fish. He was unkeen for these to basically be scraped off to central microscopy. But with that history of fish as well, clinically, this to me looked like basically microsporidia. So we started him with 1.5% levofloxacin to basically use every 3 hours. So 1 week later, his visual acuity was a little bit worse. So sometimes what happens is that when you start them on levofloxacin, they get an increase in the amount of inflammation. And so we added in some topical ointment to basically use at nighttime as well. He then basically came back again. His inflammation was basically less. I gave him a little bit of anti-inflammatory. I typically use betnosol at that time period, but you must basically keep them on the levofloxacin as well at the same time. It's important that you use the fluoroquinolone, because if you give them fluoroquinolone as well, it will clear the trophozoites as they basically come out of the cyst, and the betnosol will reduce the inflammation in the anterior chamber. And 2 weeks later, his lesions are completely cleared up. His visual acuity is okay. Even though he's G6PD, there's been no change in his blood system whatsoever on this topical therapy. So he carried on for another few weeks, and then basically we stopped this medication for him completely. So in conclusion, fluoroquinolones, as I basically showed you, work by DNA gyrase and topoisomerase 4 inhibition. Levofloxacin at 1.5% or Optiquix has demonstrated excellent safety efficacy with respect to better corneal and aqueous penetration compared to other available fluoroquinolones, and better cell viability and migration compared to Vigamox. Levofloxacin 1.5% was developed on the theory of PK/PD. So if you can get a high Cmax in the tissue, you're able to basically have a dramatic effect on inhibition resistance. And I showed you this from a theoretical standpoint. I showed you this from an experimental standpoint in animals, and also basically in a clinical standpoint in patients as well. The high Cmax has been shown in rabbit studies in the conjunctiva, cornea, and also in the aqueous humor as well. So it's not just limited to one tissue. It has a broad spectrum of activity. It's fast acting with minimal toxicity, and it also basically shows the suppression, the basic development of resistance. Thank you for your attention.
Prashant?
Yeah, thanks, Dr. Mehta. It was a wonderful elucidation of the rationale for using higher concentration antibiotics, and then gave us an overview of where specifically we can use these higher concentration antibiotics. Thank you very much. I'll now like to invite Dr. Manisha Acharya to share her experience with the higher concentration levofloxacin. Dr. Acharya is a senior consultant at Shroff Charity Eye Hospital in New Delhi, and has a lot of interest and experience in managing difficult cases of infectious keratitis. Without taking much time, I'll now like to invite Dr. Acharya to deliver her talk.
And thank you, Dr. Prashant. And at the outset, I want to thank AIOS and for giving me this opportunity.
We do have questions on the YouTube channel as well as on the web. So after this talk, we'll take the questions.
So am I audible and the slides visible? So am I audible?
Yes, yes, Manisha.
So simplifying bacterial keratitis treatment with higher concentration levofloxacin. As Dr. Vasavada in his talk, when he was telling us about the ideal antibiotic to choose, we know that the fortified antibiotics have been the mainstay whenever we were dealing with the moderate to severe bacterial ulcers. But they have their own problems like concentration, like chances of contamination, and so on. So when we got this drug, we were quite excited that this may be one of the solutions. And before saying that, I thought clinical pictures and find out from our experience.
I think we are losing connection from Manisha.
It's there now?
Your video is getting freeze.
You can stop your video, Manisha. I think that will help a little bit.
Okay, should I start?
Yeah.
Thank you. Is it better?
Yeah.
Thank you. So this 71-year-old female presented with a 10-day history of pain and redness in this eye, with history of keratoplasty around in 2016, that's around 4 years back. It was a typical infiltrate which was present at the host graft junction, a 3 into 3 millimeters. All the sutures had been removed, but there was a tag which we could see that it was still there. So when this came, we did the normal, what we do for these patients. A corneal scraping was sent, and it came out to be having gram-positive cocci. In routine, in such patients, we normally give fortified, but this time I wanted to give a monotherapy with a higher concentration, what I like the word, a pseudo-fortified levofloxacin. So we started this medicine, and the patient did start to respond within 2 days. So by day 3, the patient had resolved. The infiltrate had started to resolve, started steroids to prevent the graft going into rejection. And by day 10, we were quite out of the woods, and the vision resumed to a lot better than what the patient had presented with. This gave us a little confidence in the new drug, which was there available to us, and without any problem of fortification at our end. Then came this patient who had this 1 week history with history of grain injury. And this was a small infiltrate which was there in the center. We did a corneal scraping. Initially, I thought it may come out to be fungal, but it was KOH negative on the smear, and then we had to start an antibiotic. And with my previous experience, I started the patient again on monotherapy, levofloxacin 1.5%, and the patient did respond within a week. This was another similar case who presented with trauma history, and the inferior infiltrate was there, a moderate size, more than 4 millimeters, and started the patient on levofloxacin, and the patient did respond well to the medication. This was a one-eyed patient who was not even from Delhi, had undergone a keratoplasty along with the retina surgery, that a PPV was done with the nucleus removal, and 8 years back. Patient was doing quite well for some time, used to come for follow-ups and go back. Now came with that bad foreign body which was there inferiorly. Removed the foreign body, but definitely scared that because it did look that it had some infection around, and the foreign body removed was also plated on grams on blood agar and sent for cultures. Started the patient on levofloxacin with the loading dose, followed by an hourly application for 24 hours, and made the patient stay with us in the ward. And the patient after 24 hours was doing well, and then only sent back to his hometown. This was another case of a failed graft. We see quite a lot of these failed grafts who do not want a resurgery, but they do develop infection. So when such a case happens, now I started them with monotherapy of levofloxacin, which they can continue for a week whenever the infection subsides, and we stop them. This was a moderate, I would say a little severe infiltrate which had come up to us, this 80-year-old female with 5 days history of pain and diminution of vision. And when the patient presented, we did the gram staining, and it did show gram-positive cocci. Started the patient on the levofloxacin, and the patient had started to respond. The patient was from a secondary center and went back to the secondary center for follow-ups, and I was told that the patient was doing well. The patient already had some history of viral keratitis. So it was like a bacterial on viral keratitis. The oral antivirals were continued, and steroids started once the infection had started to resolve. And we had the culture report of streptococcus with us. These were all adult patients. Then came this 4-year-old male child with a 1-day history of pain and diminution after 1 week of uneventful cataract surgery in this eye. The left eye cataract surgery, or the other eye, had been done 6 months back, and the child was doing well with that. At presentation, that is on the after surgery, the patient's vision had gone down to 1/60, and the slit lamp examination, if you look at it, it suggests that the section is not looking a very well opposed wound, which I would like after a cataract surgery in a child. The corneal findings did show edema, but at that area there were intact sutures which could be seen. There was a lot of reaction which was present in the anterior chamber, and it was like a fibrin which was coming up. But we all err on the side of infection at that point. It was quite in the evening. To get the scraping results, it was quite difficult. So we planned for an EUA next day. And to start with, we started the patient with levofloxacin, along with, I would say here, I also gave the patient on amikacin fortified medication, which we normally give for section infection, thinking of nocardia if it was there. The patient started to respond, but if you look at that day 2 picture, the patient was doing better. The fibrin, or the reactionary part, had started to break up. You see over here, the patient also had iris bombay because the AC was shallow. Continued the patient on antibiotic and started the patient on steroids at this point as well. And within day 4, the patient had started to respond, and we looked carefully at the incision site. The incision was also looking much more healthier. And I think we had one meeting, if Dr. Prashant would remember, that at that point I was still treating this patient, and then it was discussed that we should just continue with monotherapy, and we stopped the amikacin, and by day 4 we just continued the patient on monotherapy of levofloxacin. The patient did well along with the other treatment which was given with it. The iris bombay settled, and as the days progressed, within a week started to do well. The pediatric ophthalmologist, my colleague, was definitely happy, and after that Even the other patient which we saw, she had herself started the therapy, and then after that we stopped giving the combination therapy in such cases. So, and by 2 weeks, the patient had done pretty well and was looking like a normal post-op case, which we see in pediatric cataract cases. Then came this 21-year-old male who had complaints of pain and redness for 2 days and optical penetrating keratoplasty. This is the pre-op picture when it was done 6 months back for this adherent leucoma. This is the current state when the patient presented with a 2 days history of pain and redness. If you look at the host graft junction, it is well opposed, but definitely there's a suture infiltrate which is there. A hypopion and stromal edema with DM folds present. The fundus was normal here. We did what normally is done, removed that loose suture and cultured and did the scrapings, found out whether we were dealing with a bacterial infection over there. Sorry, it was a gram-negative bacilli which had come out, and we thought we might be dealing with the pseudomonas in this case, and we started the patient again on this combination therapy with hometropine with this. The patient came out to have serratia on cultures, both on blood agar, and with the continuing the medication, the patient had started to respond. There was another loose suture, which was then removed. The sensitivity report did show that it had sensitivity to most of the antibiotics which were there. Continued the patient on the, started the patient on steroids along with the antibiotics, and the patient started to resolve with the rounding of ulcer margins as it can be seen and reduction of hypopion. And within 2 weeks, the patient was doing much better. If you look at this day 12 picture, it is responding to treatment, reduction in edema, but definitely that area is scarring up. This is in a nutshell, if you look at the clinical picture and the course of the of these suture infiltrate, this is what it is. Patient is still under follow-up with us. So these are some of the cases which I had seen, and this is just a clinical, I would say, a nutshell of one of this 17-year-old patient who developed, just on clinical picture, it looked like a wreath-like pattern and nocardia. This again was treated with monotherapy, 1.5% levofloxacin, and did well within 10 days. So this is the collection of all the cases which we have done. Now we have 10 cases, documented cases, where we have seen good response in bacterial keratitis with 1.5% levofloxacin. So I would just say that most of the identified bacterial keratitis, they did show improvement with the drug mentioned, but none of the cases had to undergo any additional procedure, tissue adhesive or therapeutic penetrating keratoplasty. Saying that, I would say that most of our cases had small to medium-sized infiltrate. In fact, the last ones were the ones which were most severe. And barring the serratia case, the others did have gram-positive bacteria only. So now after serratia case, I still feel that it's good for gram-negative as well. But for gram-positives, definitely it is a good monotherapy to be given. So to conclude, I would say that eye drop 1.5% levofloxacin in loading dose, and then the 2-hourly dose can be an effective treatment modality as a monotherapy for bacterial keratitis, although large samples need to be studied. And further long-term randomized trials need to be done to find out the efficacy in all types of bacterial keratitis if we have to respond it for that. I would like to acknowledge the contributions made by Dr. Gunjan, who's my fellow and had contributed immensely in this collection of cases. Mukesh, who's an optometrist and helped me with all the pictures which are there, the cornea services at our hospital, and the laboratory services of Dr. Shroff's Charity Eye Hospital. Thank you so much.
Thank you, Manisha, for those wonderful set of cases. Now I think we'll initiate the discussion. Dr. Prashant, would you like to comment on the various presentations?
I think one of the questions that we can start discussing is about now, since 1.5% levofloxacin is available in India, are there any kind of ocular surface toxicity with the higher concentration? If Jodhbir can share his experience in patients of non-keratitis.
Prashant, thank you. I showed that study in our talk, in the talk where it was compared in animal studies showing the effect on the surface and showing pretty much no difference. Clinically, I mean, one of the things is obviously you don't want to taper the dosing down because you want to have the high concentration there. The majority of the times we are using it in cases of infective keratitis. So we're using it in that as our basically primary treatment. And in one of the cases I showed you, in fact, that patient, we switched them off 45 medication to Crabbe 1.5% because it came from one of the outreach hospitals and stuff as well. So it wasn't available to use first line. Often in those cases anyway, you have a lot of epithelial distortion and disruption anyway, so you're going to basically improve your penetration. But I think one of the things that we do see is that once you get epithelial closure, that's when we start to see we're getting resolution of the anti-infective effect. And that's where you may start to see some toxicity issues if you're going to basically see it once the epithelium has closed and you've got resolution of the infection.
This is particularly important because in one of the cases that you showed was a microsporidia and you used 1.5% levofloxacin. So was the epithelium healthy at the end, or did you notice any changes on
No,
that?
the epithelium was fine, but we used it for a short time period for two reasons. One, because he had a very good response anyway. And the second reason was he's G6PD as well. So you don't want to keep people on, even though G6PD, I mean, I've used levofloxacin in those patients before as well because of the enzymatic effect can be quite variable, but you don't want to keep them on unless you're doing regular blood monitoring and they do punctal occlusion anyway. You don't want to keep them on levofloxacin for such a long time.
Mm-hmm. So I think one of the messages that from the group I want to convey is that I think levofloxacin 1.5% is a good tool with us to take care of the corneal infection cases, and I think we should not be using this drug for prophylaxis at this point of time. While there are no obvious toxicities on the ocular surface, more for the reason that we want to reserve this drug being a fortified concentration for more serious infections rather than as a prophylaxis.
Prashant, I think there was this question which was there on the Facebook that can we use this prophylactically before cataract surgery, before and after? And I think you very appropriately addressed that we should not, start using this drug post-operatively in our cataract patients.
Yeah. The second question that I have is, Savitri, based on your experience of in vitro susceptibility, do you see that the levofloxacin maintains a good balance of activity against both gram-positive and gram-negative infection, or it has a preferential activity toward gram-positive or one of the, say, gram-negative organism? So is this a relatively broad spectrum antibiotic or it's a selective antibiotic?
I think most studies have shown good effect on both. It's more of a broad spectrum kind of a antibiotic. Would Jyoth agree with that? I think his slides also showed some data related to this.
Yeah, I agree. Yeah.
It is good for both.
Yeah, and I think that's a very big advantage that while if you look at 8-methoxyfluoroquinolones, there you see more inclination toward activity toward the gram-positive, and the gram-negative activity is relatively inferior. Therefore, I think levofloxacin has an edge over other antibiotics. Yeah. Namrata, do you have any?
There's another question. We've already said that please don't use it for your cataract patients. So somebody's put up a question saying that can we use it in conjunctivitis?
No, I think at this point of time, because in the conjunctivitis, even the drugs that are dispensed in a lower concentration are able to achieve very good concentration. You should keep this antibiotic reserved where you want to achieve higher concentration into the corneal tissue as well as aqueous humor. So I'll say that for conjunctivitis, unless you are dealing with a very resistant conjunctivitis, it probably can be reserved for keratitis.
Okay, apart from this, what is your take on combination drugs? Like, we have a lot of combination drugs of antibiotic and steroid. and we say that you taper steroids and stop antibiotics whenever you have to stop. So, what is your take on that? Levoflox, of course, has not been combined with any steroid, but I think we need to give a clear message on that also, because people tend to use steroid antibiotic combination and then they tend to taper it in their post cataract surgery cases.
So actually, I have always been against a combination of antibiotic and corticosteroids. The rationale or the reason behind this thought process is, although the combination gives you an advantage that patient need to buy only one drop and then instill one drop that serves the purpose that they have not to remember about the two drugs. But when it comes to tapering, they start tapering not only corticosteroid, they are tapering antibiotics as well. And that really brings the antibiotic concentration into the zone where the mutation or the development of drug resistance starts. So I am not a very big fan of antibiotic corticosteroid, even in post cataract scenario. Now, when it comes to that, these drugs, if they are available in the market, and since most of these drugs are dispensed off the shelf, my worries are that these drugs will be given for other ailments as well, which may result in deterioration of their existing corneal pathology or may cause superinfection. So, for all of those reasons, I don't think so that it is a good idea to dispense combination.
So, Shail, would you like to comment on this?
Yes, I'm absolutely 100% like Prashankar sir said, that it's so common to use antibiotic steroids even for conjunctivitis, where we are not sure whether it's a viral conjunctivitis. And even when we are sure it's a viral conjunctivitis, if you want to reduce, many people use topicals low dose steroids to reduce the SPKs or inflammation. They add combine, they feel that, since we are already giving one drug, just add an antibiotic, so that in case if there is some bacterial component, that will go away. So I think we need to get a little bit more confident in our own clinical diagnosis and judgment, that if you feel this is viral, treat it as viral, and just not for the sake of, because it's available as a drug combination, just keep adding antibiotic for everything that you see red in the eye.
Another question is on the combination therapy. I think all of us are using different combination therapies. At RP Center, we are using cefazolin and tobramycin 45 drops. I don't know what Jode is using, but I know that LVPI is using cefazolin and ciprofloxacin. So, what is your combination therapy, Jode, if you have to give?
For fortified medication.
Yeah.
Yeah. So I mean, they pretty much use fortified cefazolin and gentamicin as standard. And but I think that some of the, I mean, I agree with what Prashant said. I hate combination antibiotic steroids because I think they cause more harm than good. And I think that for all of us, I mean, having to deal with these patients that come in, you're going to pick up more problems. And I know the convenience and the compliance issue, but I really don't. I mean, we don't. We can go 30 miles up the border here, and you can buy anything over the counter in Malaysia. So, and we see many people coming in, and they've been using steroids for a long, long time with huge issues with pressure or herpes or other problems in their eyes as well. So, I'm a really resistant fan for that. But we have fortified. I mean, they're the standard fortified medication that we use. We do have to use for some of the unusual bugs like Chromobacter. Now, I've been seeing a lot more of in the last, I think, year. And then they make special fortified. I mean, sometimes you can use levofloxacin, but sometimes you'll find it's resistant. The case that I showed was actually resistant to levofloxacin and amikacin as well, which is sometimes I use amikacin. The thing that I use that actually does work is tazocin. So piperacillin is something that I do use, but I'm seeing a lot more of that than I ever used to see in the last sort of like 5 years.
So, ma'am, what would determine which combination therapy to use? What really determines? Is it geographically that everybody's? I don't know. What do you use, Manisha, for your combination therapy?
Cefazolin and tobramycin.
Tobramycin. So, ma'am, what generally determines what combination therapy you have to use? I think to begin with, we were all told cefazolin and gentamicin. Rajesh, would you want to comment on this?
Yeah, actually, I just wanted to know the reason why in LVPI they are using cefazolin and ciprofloxacin, because I mean, for gram negative, there is a little bit of preference towards aminoglycoside, and so I just wanted to know from Dr. Prashant about it.
So I think let first Savitri give her view, and then I'll tell you why we are moved into that.
I think it's clear that cefazolin will tackle all the gram positives, and staphylococcus being the one which becomes resistant very easily. And large number of staphylococci show resistance. So we want to be strong in covering that. And automatically Streptococcus pneumoniae, all gram positives, they get tackled by that. So I think if at all, and they're not really so good for gram negative. So the second drug that you are using is mainly to handle the gram negatives. And earlier we were also using gentamicin as another fortified drug. So I think later on we were convinced that the effect of that fortified and ciproflox as a one drug, which is commercially available, more easily available, and patient can handle that more easily, made us change it to ciprofloxacin.
So the other reason was that we looked into the antibiotic susceptibility of gram-negative organisms, and we found that most of the gram-negative organisms had very good susceptibility for ciprofloxacin or the first generation fluoroquinolones. Further, we looked into the pharmacokinetic, and you will realize that ciprofloxacin achieved very good concentration into corneal tissue as well as aqueous humor. So we thought that when we are, until the identification of the organism is done, if we treat patient with a broad spectrum, one of the drug being available commercially, they are likely to still drop even if it is over, because that drug they can get it. Otherwise, most of the time, if you dispense these fortified drops and patient somehow is not able to come, they were discontinuing both the drugs. They were not able to use any drug. So that was the rationale that at that point of time we started ciprofloxacin. Even now, if you look into the response of Pseudomonas to ciprofloxacin, uh, you will find that if the organism is resistant to ciprofloxacin, they more or less are resistant to aminoglycosides also. So among the spectrum of gram-negative organism, unless you really move into the higher generation cephalosporin, which are active against gram-negative organism, or go to the colistin or piperacillin, uh, if the organism is cipro-resistant, you will find the aminoglycosides also are not.
Yeah, I think presently the profile shows that susceptibility of gram negatives is definitely lower for aminoglycosides, and they are somehow it's maintained for the fluoroquinolones, including Pseudomonas.
So I think.
What about ceftazidime?
Yeah.
Severe Pseudomonas, keratitis, I think it does work. Prashant, you want to say something?
No, I was telling that the same that Savitri has just alluded to, that I think it's a combination of understanding pharmacokinetics, understanding in vitro susceptibility, that we thought that if the combination is to be given, let us give this combination. And once the organism is identified and susceptibility data is available, and the clinical response is already studied, then we think about which antibiotic to move.
You can stop one and.
So I think what classically Rajesh also pointed out, that less than 3 millimeters, not involving the visual axis, it's the classical 4th generation fluoroquinolones, otherwise it's a combination therapy. So in this flow chart, where would Levoflox fit in after experience of each one of us? So I'll begin from Jodh. Jodh, when will you like to give Levoflox?
So I think
ulcers or smaller ulcers or larger ulcers or involving the visual axis, or you would like to change the way you treat?
so we use it. So certainly from Rajesh's sort of talk on the thing. I mean, certainly as first line on those smaller ulcers, I wouldn't think twice about basically using it. And then of course you wait for the scrape results, and then you can then guide yourself on the treatment from there. For the larger ulcers, it then comes down to a little bit on the fact that you've got to look at patient compliance. You've got to look at patient side effects with toxicity, based using the gentamicin. Obviously, preservative issues with that's going to be preservative free formulation. We do use it quite frequently, where we will generally sometimes we will stop the we'll keep them on the KEF, and then we'll add in the levofloxacin, and we'll see the response to how the patient basically is responding, and then we will basically alter the topical medication in that way. But we will try to then get them off the gentamicin, especially if there's any issue with ocular surface problems that we're seeing with the gentamicin, or if they're patients with ocular surface disease. So we have quite a low threshold of switching patients basically onto levofloxacin 1.5%.
Manisha, you would want to say you treated so many patients. Are you going to start treating all of them with levoflox, or?
As a first line now, most of the patients I start on levofloxacin and wait for the culture reports if it's coming, because the spectrum, what it is saying, is pretty broad. But if it comes out to be resistant or something, or till now, I'm still treating the like iatrogenic infections, which may be like post LASIK or post PRK infections. We recently had one referred to us. So those patients still on the previous starting them on fortified. Otherwise, now routine contact lens induced keratitis and bacterial, I start levofloxacin 1.5 as the first line, and then wait for the culture reports and then switch if needed.
So Prashant, what is your take on it? First line.
So yeah, my take will be that I think wherever we were recommending monotherapy with fluoroquinolones, that will be definitely a first indication, realizing the reduced susceptibility of MOXIE and GATI. In addition, I will consider cases which have low risk of extending into the limbus or low risk of perforation, and even if they are 5 millimeter or 6 millimeter in size. The third will be where you have exhausted or you have used the fortified drops for time, and now you want to switch over to another antibiotic because patient cannot come to collect these fortified drops. Then probably this will be a good choice to switch over from fortified over to the monotherapy. So I think these will be the three indications. All patients with the 6 millimeter or larger, where there is a risk of perforation or extension into the sclera, we will continue to treat them with fortified antibiotic combinations.
Rajesh, you want to say something?
Yeah, actually, most of the things what Dr. Prashant has said, that smaller ulcers, even in smaller ulcers, many times we do hesitate in using monotherapy. But here, I think the kind of response that we are getting with the 1.5% levofloxacin, one may not hesitate in using monotherapy in smaller ulcers. And also, if it's a slightly larger ulcer, but the patient is coming from far-flung area, cannot come for getting the drugs made, I mean, we can go ahead and use this. For larger ulcers, I will still, I mean, I'm not too sure about it unless I do it myself, randomized study. So for larger ulcers, I will still go ahead with a combination therapy. My one concern that I was feeling when all these presentations were going on is that what if the company promotes it for post-cataract surgery? Then again, another drug which is so good for keratitis is going to have issues.
So, ma'am, how are we going to, my next question was to you, how are we going to, ensure that there is going to be no resistance to it, in the future? Vancomycin, we do understand, because vancomycin has to be prepared. It is not available on the counter, and, we don't generally, so that's kept as a last drug. But what are we?
Yeah, I think the only way it should be that it shouldn't be available in the shops over the counter. that anybody with the pharmacist becomes an ophthalmologist. Actually, he becomes a doctor, and anyone goes to the pharmacist with red eye, he'll straight away give the levofloxacin. I think that's the only way you can control it. I don't know how in India it's very, very difficult once it is in the market.
So Prashant, would you like to?
So what do you think about subscribing or prescribing it only for a given type of patients will not hold true at all if it is in available.
I think the company has to play an important role, and I don't know how far they are, willing to go in this direction. They should, because it's a high concentration drug, and we do not have too many fortified drugs, given the situation that fortified concentration commercially available is not, this high concentration is not available commercially. I think we should reserve it for infections which deserve it, rather than for all kind of infections. So I think with this, if there are any other comments, otherwise I will ask Dr. Prashant. I will ask him. I'll request him to please uh, give his remarks and the take-home messages from this webinar.
Yeah, no, I think it was a wonderful webinar. I would like to thank AIOS for organizing this meeting on a very important topic. Um, um, and I would like to thank all the speakers for very eloquently elucidating on this topic. Dr. Jodhbir Mehta, who is uh, pretty late in the night, but I think we would like to thank you for sharing your experience. The drug has been available in Singapore for a much longer time, and you have a lot of experience with that. I'm sure that we are going to be benefited from this experience. My take home message will be that drug resistance is a significant problem in India. And I think we all, as an ophthalmologist, have a responsibility not only to sensibly use antibiotic, but also to understand the basic principles of drug dispensing and become ambassador with the government, with other agencies in ensuring that the antibiotics are reserved for the indication that they are made for. I think as a clinician, we have that responsibility. Otherwise, we are going to enter in a pre-antibiotic era where there will be a lot of morbidity and financial burden from infectious diseases. So this webinar, this initiative of All India Ophthalmic Society is in the right direction, and I like to thank Dr. Namrata Sharma and other members of the committee of All India Ophthalmic Society for giving us this opportunity to share with all the participants our views on drug resistance. I will also like to thank Centane for sponsoring this webinar. And one of the advice that the group felt will be if they really can follow not promoting this drug for prophylaxis against infection. With these words, I'd like to thank all the participants and AIOS for really conducting or for organizing this webinar. Thank you very much.
Thank you
Thank
very
you.
much.
Good night.
Thank you, sir.
Thank
Thank you,
you.
ma'am.
And
Thank you.
Thank everybody. George, you can go to sleep.
Thank you.
You can go for dinner now.
Yes.